Welcome back to the deep dive. Today we are tackling, well, really a masterclass in some pretty high-stakes pharmacology.
hmm
We're diving deep into obstetrics. This is a field where, precision and really understanding how drugs work directly impacts two patients at the same time, the mother and the fetus.
That's exactly it.
So our mission today is to get to that kind of elite professional mastery, moving past just the definitions to really dissect the clinical use, the critical timings, and of course the safety trade-offs of these powerful drugs used in delivery and high-risk pregnancy.
Yeah, absolutely. You can think of the pharmacology here as having sort of four main levers. You've got the drugs that stimulate uterine contractions, those are the oxytocics. Then drugs that stop labor, the tocolytics.
Okay.
Then you have agents managing systemic things like blood pressure, fluid balance. And finally, pain management strategies, which are crucial for a safe delivery. Understanding these down to the molecular level really helps you anticipate the risks involved.
Okay, let's unpack this. It's quite a lot of dense clinical science. We'll start primarily with the three big classes of oxytocics, sometimes called ecbolics too, right? Oxytocin, the ergot derivatives, and prostaglandins.
Correct.
But the roadmap, as you said, it's pretty comprehensive. We've got to cover the safety profiles around antihypertensive therapy, diuretics, tocolytic agents for preterm birth, anticonvulsants and eclampsia, and, well, the absolutely non-negotiable principles of teratology and anesthesia.
And for listeners, if you really need to master this stuff, it's not just about knowing the drug names. It's knowing the dose calculations, the monitoring you need, and maybe most critical, when a drug is absolutely not okay to use the contraindications. That's really the sign of expertise here.
Right, let's start with the absolute cornerstone, oxytocin. Chemically, it's pretty foundational, a non-peptide. That means a chain of 9 amino acids. And there's Nobel Prize history here, isn't there?
There is, yeah. Davigneau and his coworkers got the Nobel back in 1950 for figuring out its structure. And that work was what allowed us to make it synthetically.
Which is huge, clinically.
Huge. Structurally, it's fascinating where it comes from. Synthesized way up in the brain, specifically the supraoptic and paraventricular nuclei of the hypothalamus.
What's up there?
Then it travels down nerve axons to the posterior pituitary gland. That's where it's stored, ready to be released when the body gives the signal.
And thinking pragmatically in the body, oxytocin is, well, it's a fleeting messenger, isn't it? The pharmacokinetics show this incredibly short half-life.
Just 3 to 4 minutes, yeah.
Wow. And the duration of action is only about 20 minutes.
That rapid breakdown is thanks to an enzyme called oxytocinase, which, interestingly, is really abundant during pregnancy.
Okay.
So that short duration is exactly why you need continuous infusion. You can't just give a single shot.
Right. And what's really fascinating is how the uterus prepares for it. It's not just sitting there passively waiting.
Not at all.
Yeah.
It actively gears up. The concentration of oxytocin receptors in the myometrium, the uterine muscle, it skyrockets during labor. We're talking a 100 to 200-fold increase.
100 to 200 times.
Yeah. And that massive upregulation, that's the key insight. That explains why oxytocin doesn't really work early in pregnancy, but is so incredibly powerful once labor is truly underway.
So the mechanism is all about calcium then, the sort of universal trigger for contraction.
Exactly. Oxytocin hits its specific receptors, works through voltage-gated calcium channels, and gets things started. It mobilizes intracellular calcium from storage, from the sarcoplasmic reticulum. Plus, it has a secondary effect. It stimulates local prostaglandin production in the amniotic membranes and the decidua.
So it sort of fuels the fire, too.
It helps keep the labor process going, yeah. But here's a really critical clinical point, essential for safety during delivery. Oxytocin causes what we call a physiological contraction.
Physiological contraction.
Meaning the contraction starts powerfully at the top, the fundus of the uterus. But crucially, it allows the cervix, the bottom part, to relax and open. Maintaining that physiological polarity is absolutely vital for the baby to descend safely.
Okay, that makes sense. So in the clinic, what are we actually using? It's synthetic oxytocin mostly.
Primarily, yes.
Yeah.
Brands like Syntocinon or Pitocin are common.
Yeah.
They usually come in ampoules of 5 international units, or IU, per milliliter. The big advantage of the synthetic form is you get just the oxytocic effect, the contraction effect, without any unwanted vasopressor action, meaning it doesn't raise blood pressure significantly.
That's a safety feature.
Definitely. Now, you also see combination forms. Syntometrin, for instance, mixes 5 IU of Syntocinon with 0.5 milligrams of ergotamine. We'll get to ergotamine in a bit.
Okay.
And there's also something called decimino-oxytocin. It's an analog, much more potent, 50 to 100 times more effective. And importantly, it isn't broken down by oxytocinase.
Ah, so it lasts longer?
Much longer.
Uh.
It's sometimes given as buccal tablets, dissolved in the cheek.
And yeah, it's worth saying again about that effectiveness variability. The sources really stress this. The uterus is almost refractory, resistant in the first trimester, still relatively resistant in the second. It only gets highly sensitive late in the third trimester, near term, or during labor. It's like a natural safety lock.
Absolutely. And just a practical point, proper storage is key for potency. Needs to be kept refrigerated between 2 and 8 degrees Celsius. ##B, therapeutic and diagnostic applications of oxytocin.
Okay, so where do we actually use it therapeutically?
It's got a pretty broad range of uses. Early in pregnancy, it might be used as an adjunct, sort of alongside other methods to speed up an inevitable or missed abortion, or maybe help expel a hydatidform mole.
Okay.
It can also help control bleeding after the uterus has been evacuated.
And then later in pregnancy and during labor itself, that's where it really
Right.
comes into its own, right?
That's its main role. Inducing labor if it hasn't started, ripening the cervix sometimes, augmenting labor if contractions are weak, or slowing down what we call uterine inertia. And critically important for the active management of the third stage of labor.
To prevent hemorrhage.
Exactly. To minimize blood loss and control postpartum hemorrhage, PPH. That's a major killer globally, so effective oxytocin use is vital.
Now, the administration, this is where the real skill comes in, isn't it? You said continuous infusion.
Yes, absolutely. You almost never give it as a rapid IV push or bolus. The standard is a controlled intravenous infusion. And ideally, you're using an infusion pump for maximum accuracy.
Right. Keeps the fluid load down, too.
And gives you precise control. The technique is called oxytocin titration.
Titration. Okay. How does that work?
You start really low, like 1 to 2 million units per minute. That's imiumin. Then you increase the dose very slowly, maybe adding another 1 to 2 imiumin every 20 to 30 minutes.
So slow and steady.
Very steady. You continue this gradual increase until you get the optimal response. And that's defined as about 3 contractions every 10 minutes, with each one lasting around 45 seconds, and importantly, with enough relaxation time in between.
And you mentioned expressing the dose in imiumin. Why is that specific unit so important?
It standardizes everything. It doesn't matter how concentrated your IV bag mix is. Expressing it in milliunits per minute gives you a consistent measure for safe regulation. For example, if you put 2 units of oxytocin into a 500 milliliter bag of Ringer solution and you run that drip at 60 drops per minute, that translates to delivering 8 imiumin.
Got it. Clinicians need to be able to do that calculation quickly.
Instantly and accurately.
Yeah.
And during the infusion, monitoring is just relentless. You've got to note the flow rate constantly. You monitor the uterine contractions, how many, how long they last. Is there good relaxation between them? You can do this by just feeling the uterus with your fingertips, or ideally with continuous electronic monitoring.
And you're aiming for a specific pressure.
Yeah, the ideal intrauterine pressure during a contraction peak is about 50 to 60 millimeters of mercury. But just as important is the resting tone between contractions that needs to stay low, around 10 to 15 millimeters of mercury.
Okay, what about the baby?
Fetal safety is paramount. You check the fetal heart rate, the FHR, every 15 minutes, or even better, use continuous electronic fetal monitoring, EFM.
Right. So when do you hit the brakes? When do you stop the infusion?
Immediately. If you see tachysystole, that means contractions are coming too close together, less than 2 minutes apart, or they're lasting too long, more than 60 seconds, or if that resting tone between contractions starts to creep up.
So too much contraction is dangerous.
Very. Any sign of fetal distress on the monitor or any concerning maternal symptoms like sudden changes in blood pressure or heart rate, that's an absolute stop signal. Infusion off.
What are the main dangers we're watching for?
On the maternal side, things like arrhythmias, nausea, vomiting can happen. But the really serious risks are uterine hyperstimulation, that tachysystole or hypertonia we just mentioned, that can actually lead to uterine rupture.
Rupture, that sounds terrifying, especially in certain patients.
Exactly. The risk is much higher in women who've had many babies before the grand multipara, or someone with a scar from a previous C-section or uterine surgery, or if there's a known contracted pelvis where the baby might not fit through easily.
And you mentioned water intoxication earlier. How does that happen with oxytocin?
Right, this is a big one. At higher doses, usually above 30 to 40 imiumin, especially if you're infusing it with large volumes of fluids that don't contain salt, like dextrose solution, for a long time, oxytocin actually acts a bit like antidiuretic hormone, ADH.
Ah, so it makes the body retain water.
Precisely. This leads to water intoxication, which causes hyponatremia, low sodium levels in the blood. That can manifest as confusion, seizures, coma, even heart failure. Prevention is key. Strict monitoring of fluid intake and output, and if high doses are really necessary, making sure it's given in a salt-containing solution like Ringer's lactate or saline.
Okay. And the risks to the fetus.
They stem directly from that hyperstimulation. If the uterus is contracting too much or not relaxing properly, it severely cuts down blood flow through the placenta.
Which means less oxygen for the baby.
Exactly. Leading rapidly to fetal distress, hypoxia, and potentially tragically fetal death.
So given all that, the contraindications make sense. Grand multiparity, contracted pelvis, previous uterine scar.
Obstructed labor, certain maternal cardiac diseases,
Yeah.
if the mother is hypovolemic, or if there's already evidence of fetal distress before you even start, you just wouldn't use it in those situations.
Okay. Now, besides treatment, you mentioned a diagnostic use, the contraction stress test.
Yes, the CST, sometimes called the oxytocin challenge test, or OCT.
What's that for?
It's basically an invasive way to check fetal well-being. You carefully induce some uterine contractions using a very dilute oxytocin infusion and watch how the fetal heart rate responds. The idea is to simulate the stress of labor and see if the fetal placental unit can handle that temporary decrease in blood flow during a contraction.
So you're sort of stress testing the system. How do you interpret the results?
It's quite detailed. A positive CST is the worrying one. It means you see persistent late decelerations in the fetal heart rate, following 50% or more of the contractions. That's a strong indicator the baby might be hypoxic.
And negative is good?
Negative is ideal. No late decelerations, no significant variable decelerations. Then you can have suspicious results with intermittent concerning patterns. Unsatisfactory if you couldn't get enough contractions to interpret it. And hyperstimulation if decelerations occur, but only because the contractions were too strong or too frequent.
Okay. Is it definitive?
Not entirely. The big caveat with the CST is the false positive rate, which can be as high as 50%. So a positive test doesn't automatically mean disaster, but it absolutely warrants further, more sophisticated investigation, like a biophysical profile or Doppler ultrasound studies.
Okay, let's shift gears to the second class, the ergot derivatives. You mentioned ergometrin or ergonovine and methergine.
Yes, methergine is methyl ergonovine. Both are synthesized from lysergic acid, which comes from the ergot fungus.
And their mechanism, you said it's very different from oxytocin.
Critically different. Ergot derivatives act directly on the uterine muscle, the myometrium, but they cause the entire uterus to clamp down in a continuous spasm. It's a true tetanic contraction.
Tetanic, like lockjaw.
Similar principle, yeah. There's a complete loss of that physiological polarity we talked about with oxytocin. No coordinated fundal contraction with cervical relaxation. And crucially, there's virtually no relaxation period between contractions. It just clamps down hard.
Wow. So why would you want that kind of contraction?
For one very specific, very important reason. Hemostasis, stopping bleeding. That powerful, sustained clamping action is incredibly effective at shutting down the bleeding sinuses in the uterine wall right after delivery or after an abortion. It's a lifesaver in managing postpartum hemorrhage, PPH.
Okay, so its role is purely stopping bleeding after the baby is out.
Absolutely. And because it causes this intense, non-physiological tetanic contraction, the timing is a non-negotiable. You must not use ergot derivatives to induce labor or abortion. That would be catastrophic.
Why? What would happen?
It could trap the baby, especially if there was an undiagnosed second twin. It could cause uterine rupture because the cervix isn't relaxing. So the rule is strict. Only give it late in the second stage, typically after the baby's anterior shoulder is delivered or immediately after the baby and placenta are completely out.
Got it. Are there differences between ergometrin and methergine?
Slight difference in onset. If given intravenously, IV methergine takes a bit longer to act, about 96 seconds, compared to around 55 seconds for IV ergometrin. Symptometrin, that combination product, is usually given intramuscularly, IM only, but once they kick in, they all last quite a while, typically around 3 hours.
And the downsides? The hazards?
They stem directly from that powerful action, particularly their vasoconstrictive effect. They constrict blood vessels significantly.
Ah, so blood pressure issues.
Big time. They can cause a sudden, dangerous spike in blood pressure. This carries risks of serious cardiovascular events like myocardial infarction, a heart attack, or stroke. With repeated use, there are even reports of peripheral gangrene because of the reduced blood flow.
That's serious.
Very. The more common side effects are nausea and vomiting, which happen quite frequently. They can also interfere with lactation by lowering prolactin levels.
Okay, so the contraindications must be pretty strict too.
Absolutely. You wouldn't use them if you even suspect there might be twins still inside. Definitely not in women with organic cardiac diseases, severe preeclampsia or eclampsia, because the BP spike could trigger seizures or any severe hypertensive disorder or vascular disease. And again, never during labor induction.
All right, on to our third class, prostaglandins, or PGs. These sound different again. Local hormones.
Yeah, that's a good way to think of them. They're derivatives of something called prostanoic acid. They generally act as local hormones, meaning they work paracrine or autocrine right in the tissues where they're made or on the cells that made them. Key tissues in pregnancy are the decidua, the fetal membranes, and the myometrium itself.
And the types. You mentioned PGE1, PGE2, PGF2A.
Those are the main ones in obstetrics. The E and F refer to their chemical structure, and the subscript number, like 2 or 1, indicates the number of double bonds. They're formed from arachidonic acid, a fatty acid.
Where do they come from specifically?
Different tissues specialize. The decidua, the uterine lining, is a major source of PGF2A. The fetal membranes, particularly the amnion, produce a lot of PGE2, and the myometrium itself produces PGI2, which tends to be more inhibitory. Importantly, they get broken down quickly, inactivated in the lungs and liver, which helps keep their action localized.
Okay, so how do they work on the uterus?
They're very versatile. Unlike oxytocin, which really needs that receptor upregulation near term, prostaglandins promote myometrial contraction regardless of how far along the pregnancy is.
Oh, interesting. So they can work earlier.
They can. They also seem to sensitize the uterine muscle to oxytocin, sort of priming it for labor. PGF2A is mainly about contractility. But PGE2 is particularly interesting because it does more than just cause contractions.
What else does it do?
PGE2 is key for inducing labor because it also promotes cervical ripening. That's the softening, effacement, and dilatation of the cervix. It has this unique collagenylytic property.
Collagenylytic. It breaks down collagen.
Essentially, yes. It helps dissolve the dense collagen bundles in the cervix and increases the water content in the tissue. This transforms a firm, unripe cervix into one that's soft and ready to open. That's why putting PGE2 gel directly onto the cervix is considered the gold standard for cervical ripening before induction.
Right, so it prepares the exit route as well as stimulating contraction.
Exactly. And PGE2 seems to be significantly more potent than PGF2A, maybe 5 times or more.
What about the actual drugs? What forms did they come in?
PGE2 is available as dinoprostone, brand name Prostin E2. You can get it as vaginal tablets, a vaginal pessary like Propess, which releases it slowly, or as a gel for direct cervical application. The main drawback is it usually needs to be kept refrigerated.
Okay, and PGE1?
That's misoprostol, and misoprostol has some major advantages, especially in, say, resource-limited settings. It's much cheaper than PGE2. It's stable at room temperature, so no need for refrigeration. It has a long shelf life.
And how is it given?
Very flexibly. Orally, vaginally, buccally in the cheek, or sublingually under the tongue. Clinically, using misoprostol often leads to a shorter time from induction to delivery, and you might need less oxytocin later on to augment labor.
Sounds great. What are the catches, the risks?
Well, they definitely have side effects. Nausea, vomiting, diarrhea are common. Some people get fever, chills, tachycardia. PGF2A specifically carries a risk of bronchospasm, so it's avoided in asthmatics.
Okay, and the big risks?
The major concern, similar to oxytocin but potentially even higher with prostaglandins, especially misoprostol, is uterine hyperstimulation tachysystole. And because they are so potent, there's a significantly increased risk of uterine rupture, particularly if the woman has had a previous C-section or other uterine surgery. That's a huge safety concern.
Right, so contraindications would include previous scar.
Definitely a major one, especially for misoprostol. Also, hypersensitivity to the drug, active heart, lung, kidney, or liver disease. PG2 can cause hypotension, so that's a concern. And as I mentioned, bronchial asthma for PGF2A.
Before we leave oxytocics, what about carbetocin? I've heard of that.
Ah, yes, good point. Carbetocin is a long-acting synthetic analog of oxytocin. Its main use is for preventing PPH, especially after a cesarean delivery, when uterine atony, or lack of tone, is a risk. Its big advantage is that single dose provides uterine contraction for much longer than standard oxytocin, getting around that short half-life problem.
Okay, let's move on to modulating the mother's system, specifically blood pressure. Why is antihypertensive therapy so critical in pregnancy?
It's all about protecting the mother from the really severe acute complications of high blood pressure. We're talking about preventing eclampsia seizures, preventing cerebral hemorrhage or stroke, avoiding acute cardiac failure, and reducing the risk of placental abruption, where the placenta detaches prematurely.
So the goal is just to get the blood pressure down.
Down to a safer level, yes.
Yeah.
Generally aiming for a mean arterial pressure below 125 millimeters of mercury, or keeping the systolic below 140 and diastolic below 90, especially if there's concern about target organ damage.
What drugs do we use? Is there a preferred order?
Yes, there's definitely a hierarchy based on safety and effectiveness data in pregnancy.
Hmm.
First-line choices are usually methyl-dopa. It's been around a long time, works centrally and peripherally, and has a very good safety record for both mother and baby.
Okay.
And labetalol. That's a combined alpha and beta adrenergic blocker. Also considered very safe and effective first line.
What if those aren't enough? Second line.
Second line often involves nifedipine. It's a calcium channel blocker. Works by directly relaxing the smooth muscle and arterioles, causing vasodilatation.
And what about a real hypertensive crisis, like dangerously high pressure?
For emergencies, we need faster, more potent vasodilators. Hydrolysine is one option. Nitroglycerin can be used. It relaxes both veins and arteries. And then, really as a drug of last resort, there's sodium nitroprusside.
Last resort. Why is that?
Because while it's a very powerful direct vasodilator, it gets metabolized in the body to cyanide and thiocyanate.
What is cyanide?
Yes, and those metabolites are toxic, especially to the fetus. So if nitroprusside has to be used, it's only for extremely short periods, maybe just 10 minutes or so, in a highly monitored intensive care setting to get the pressure down quickly before switching to something safer.
Okay. And are there drugs that are completely off limits, absolutely contraindicated?
Yes. This is crucial.
Yeah.
Angiotensin-converting enzyme inhibitors, the ACE inhibitors like captopril or lisinopril, and the angiotensin receptor blockers, the AARBs. These classes are absolutely contraindicated throughout pregnancy.
Why? What do they do to the fetus?
They can cause severe fetal harm. Things like oligohydramnios, low amniotic fluid, likely due to effects on fetal kidneys. They can cause fetal renal tubular dysgenesis, which basically means the kidneys don't develop properly, potentially leading to neonatal renal failure and death. So absolutely avoid ACE inhibitors and AARBs. Hashtag PASOB, diuretics, and fluid management.
Okay, what about diuretics or water pills? When might they be used in pregnancy?
They're used quite cautiously, actually. The main indications would be pregnancy-induced hypertension, PIH, but specifically when there's significant pathological edema, severe swelling. Also maybe in eclampsia if there's pulmonary edema, fluid in the lungs, or sometimes in severe anemia if the mother develops heart failure. They can also be used sometimes as an add-on to certain antihypertensive drugs.
Why the caution?
Because the main action of diuretics is to remove fluid and reduce plasma volume, and that's the core issue.
What drugs are we talking about?
Commonly used ones include furosemide, also known as Lasix. That's a loop diuretic. Works mainly in the loop of Henle in the kidney to block sodium and potassium reabsorption. It's often given parenterally, IV or IM, in acute situations like pulmonary edema.
Okay.
Thiazide diuretics are sometimes used alongside antihypertensives and are generally considered relatively safe if needed. And then there's spironolactone, which is potassium sparing. It might be used to boost the effect of thiazides or loop diuretics, but you have to be careful because it's contraindicated if the patient already has high potassium levels, hyperkalemia.
Right, so back to the caution, the main hazard is reducing plasma volume.
Exactly. Here's the critical trade-off. In conditions like preeclampsia, the mother's circulating plasma volume is often already lower than it should be physiologically.
So using a diuretic could make that worse.
Precisely. Further reducing that already compromised plasma volume can directly lead to decreased blood flow to the placenta. Diminished placental perfusion means less oxygen and nutrients for the fetus, potentially causing fetal compromise or growth restriction.
So it's a real balancing act.
A very delicate one. Besides the placental perfusion risk, diuretics can also cause maternal hypokalemia, low potassium. And there are potential fetal issues reported, like thrombocytopenia, low platelets, or hyperglycemia, high blood sugar, especially if the mother is diabetic. So the decision to use a diuretic, especially in preeclampsia, needs very careful consideration.
Okay, let's switch to tocolytics. These are the drugs used to stop preterm labor, right?
Correct. Tocolysis means stopping uterine contractions. The main objective here is usually short-term, though. We're typically aiming to delay delivery for about 48 hours.
Just 48 hours. Why that specific time frame?
Two critical reasons. First, that 48-hour window gives us enough time to administer corticosteroids, like betamethasone, to the mother. These steroids cross the placenta and significantly accelerate the development of the fetal lungs, reducing the risk of respiratory distress syndrome if the baby is born preterm.
Okay. Buys time for the lungs to mature.
Exactly. And the second reason is it allows time for intrauterine transfer. If the mother is at a hospital without a specialized neonatal intensive care unit, or NICU, delaying delivery for 48 hours gives time to safely transfer her to a center that is equipped to handle a very preterm infant.
Makes sense. So what drugs do we use for tocolysis? What are the mechanisms?
There are several classes with different mechanisms. One that's widely used, though maybe more for other reasons now, is magnesium sulfate, text MgSO44.
Magnesium sulfate again. We just talked about it for eclampsia.
Yes, it's versatile.
Yeah.
As a tocolytic, its proposed mechanism is competitive inhibition of calcium ions at the muscle cell level. Interestingly, while it's common, the source material notes it actually has a relatively poor intrinsic tocolytic effect compared to others.
So why use it?
It's considered relatively safe, provided you monitor carefully. You watch for signs of toxicity, loss of deep tendon reflexes like the knee jerk, decreased urine output, and importantly, respiratory depression. It's contraindicated in women with myasthenia gravis or severely impaired kidney function. Its main use now in preterm labor is often more for fetal neuroprotection, reducing the risk of cerebral palsy rather than purely stopping contractions long term.
Okay, what else?
Calcium channel blockers, like nifedipine. We mentioned it for hypertension, but it also works as a tocolytic by blocking calcium entry into smooth muscle cells, relaxing the uterus.
Any specific warnings with nifedipine?
Yes, a crucial one.
Yeah.
You have to be extremely cautious about using nifedipine and magnesium sulfate together. They can have a synergistic effect, leading to profound maternal hypotension, low blood pressure, and potentially neuromuscular blockade.
Right, avoid that combo. What's next?
The beta mimetics, drugs like terbutaline or ritodrine, these stimulate beta-2 adrenergic receptors.
Beta-2, like asthma inhalers.
Similar receptor type, yes. Stimulating beta-2 receptors in the uterus leads to smooth muscle relaxation by reducing intracellular free calcium. They can be quite effective for achieving that 48-hour delay.
But, sounds like there's a but.
Big but. They come with significant maternal side effects. Because they also stimulate beta receptors elsewhere, they can cause severe tachycardia, rapid heart rate palpitations, tremors, anxiety, pulmonary edema, fluid in the lungs, even cardiac failure in susceptible women. They can also cause hyperglycemia and hypokalemia, so their use has declined a lot due to these risks.
Okay, less popular now. Any others?
Yes, cyclooxygenase inhibitors, often called COX inhibitors. Indomethacin is the main example here. They work by reducing prostaglandin synthesis, and since prostaglandins drive contractions, this can stop labor.
Sounds effective. Risks?
Significant fetal and neonatal risks, unfortunately, especially if used later in gestation, generally after 32 weeks. The main concerns are premature constriction or closure of the ductus arteriosus, a fetal blood vessel, which can lead to pulmonary hypertension in the newborn. They can also cause oligohydramnios, low amniotic fluid, and potential kidney problems in the baby. So use is usually limited to very specific situations and earlier gestations.
Right. Are there more targeted approaches?
Yes, we have oxytocin antagonists, like atosiban. This drug specifically blocks the oxytocin receptors on the myometrium and also inhibits calcium release, directly counteracting labor signals. It tends to have fewer maternal side effects than the beta mimetics.
That sounds promising.
It is, though maybe less potent than some others. And finally, nitric oxide donors, like glycerol trinitrate, GTN patches, or IV. Nitric oxide is a smooth muscle relaxant, so it can relax the uterus. It might also help with cervical ripening. Research is ongoing there.
Now, let's talk about convulsions, specifically eclampsia. The principle is...
In pregnancy, if a woman has a seizure, you have to assume it's eclampsia until proven otherwise. It's the most common cause and the most dangerous one in this context.
And the drug treatment is clear.
Absolutely clear. The undisputed drug of choice worldwide for both preventing seizures in severe preeclampsia and treating active eclamptic convulsions is magnesium sulfate, text MgSO41.
Back to mag sulfate. It really is a workhorse. How does it work for seizures?
Its mechanism in eclampsia is thought to be multifaceted. It acts as a cerebral vasodilator, increasing blood flow to the brain, which might counteract the vasospasm thought to contribute to seizures. It blocks calcium channels at the neuronal level, reducing nerve excitability. It also decreases the release of the neurotransmitter acetylcholine at the neuromuscular junction, acting like a central nervous system depressant.
So it calms things down in the brain.
Essentially, yes. And importantly, it does this without sedating the mother or depressing the baby significantly, unlike some other anticonvulsants.
Is there a target level in the blood?
Yes. Achieving and maintaining a therapeutic serum magnesium level is key, typically between 4 and 7 in milliQL, milliequivalents per liter. Below that, it might not be effective. Above that, the risk of toxicity increases sharply.
And toxicity means?
Loss of reflexes, muscle weakness, respiratory depression, and eventually cardiac arrest at very high levels. That's why continuous monitoring is essential, checking reflexes, respiratory rate, urine output.
Is there an antidote if toxicity occurs?
Yes, thankfully. The immediate antidote is calcium gluconate, usually given as a 10% solution intravenously. Calcium directly antagonizes the effects of magnesium at the cellular level.
Good to know. Are other anticonvulsants ever used?
Generally avoided for eclampsia specifically because mag sulfate is so much better and safer. Diazepam, a benzodiazepine, is a potent muscle relaxant and anticonvulsant, but it causes significant neonatal depression, hypotonia, poor feeding, hypothermia, respiratory issues which can last for weeks because the baby metabolizes it very slowly. So really not ideal in labor. Phenytoin is another powerful anticonvulsant, often used for status epilepticus outside of pregnancy. But if a woman with pre-existing epilepsy needs to take it during pregnancy, especially the first trimester, there's a known risk about 5 to 10% of fetal hydantoin syndrome.
Fetal hydantoin syndrome, what does that involve?
It's a pattern of birth defects, including characteristic craniofacial features like a broad nasal bridge, cleft lipolate, and hypoplasia, or underdevelopment, of the distal phalanges, the fingertips, and toes. So again, magnesium sulfate remains the clear standard for eclampsia itself.
All right, this feels like a really critical section. Teratology. Safety regarding birth defects. What exactly is a teratogen?
A teratogen is defined as any agent could be a drug, a chemical, an infection, radiation that can cause a permanent abnormality in the structure or function of an organ or system, provided the exposure occurs during embryonic or fetal development.
Permanent alteration. Okay.
Yeah.
How do these agents actually cause harm? What are the mechanisms?
It's complex and varies. We know some mechanisms quite well. For instance, folic acid deficiency is strongly linked to neural tube defects like spina bifida.
Right, hence the recommendation for folic acid supplements.
Exactly. Another mechanism involves harmful intermediary metabolites. Some drugs, like the anticonvulsants phenytoin, hydantoin, or carbamazepine, get broken down into reactive molecules called epoxides or arena oxides, and these metabolites might be the actual culprits causing damage.
It's not the drug itself, but what the body turns it into.
Sometimes, yes. We also know that some teratogens interfere with fundamental genetic processes. For example, retinoic acid related to vitamin A, found in drugs like isotretinoin used for acne, can severely disrupt the function of homeobox genes. These are master control genes essential for patterning the embryo.
Wow, messing with the master plan.
Pretty much. And often it's an interaction between the gene susceptibility of the fetus and the environmental exposure.
You mentioned exposure timing. How critical is that?
It is absolutely everything in teratology. The sources lay out a clear developmental timeline with different windows of vulnerability. Before implantation, around day 31 post-last menstrual period, exposure tends to have an all-or-none effect.
All or none.
Meaning either the exposure is lethal and causes a very early pregnancy loss, often before the woman even knows she's pregnant, or the embryo survives and typically develops without major malformations from that specific exposure. There's significant repair capacity very early on.
Okay. What happens after day 31?
From about day 31 to day 71, that's roughly the first trimester proper. This is the period of major organogenesis when all the major organs like the heart, limbs, brain are forming. Exposure to a teratogen during this critical window is when you get the major structural malformations. The specific defect often depends on exactly when during this period the exposure occurred, coinciding with the development of that particular organ.
So that's the highest risk period for major birth defect.
For major structural defects, yes. But development doesn't stop at day 71. Growth and functional maturation continue throughout the rest of pregnancy. Exposure later on, after day 71, tends to cause issues more related to growth retardation, functional deficits, or problems in systems that mature later, like the central nervous system. Fetal alcohol syndrome, for example, can result from alcohol exposure throughout pregnancy, including later stages, affecting brain development and function.
Right. So how do clinicians manage this risk? There are those FDA categories, aren't there?
Yes, the FDA established pregnancy risk categories to provide guidance. Though they're being phased out for a newer labeling system, the principles are still useful to understand. Category A was the safest, adequate, well-controlled studies in pregnant women showed no risk. Very few drugs fall into this category. Category B meant either animal studies showed no risk, but human studies were lacking, or R, animal studies showed risk, but human studies did not. Category C was basically risk cannot be ruled out. Animal studies might show risk, or there might be no studies at all. Drugs were given only if the potential benefit clearly justified the potential risk to the fetus. Many drugs fall here.
So A is good, C is caution. What about D and X?
Those are the critical ones. Category D means there is positive evidence of human fetal risk based on adverse reaction data from investigational or marketing experience or studies in humans. However, the potential benefits of using the drug in pregnant women might still be acceptable despite the risk, for example, if the drug is needed for a life-threatening illness or a serious condition for which safer drugs cannot be used or are ineffective.
So a serious risk-benefit calculation needed for D.
Absolutely. But category X, these are drugs where studies in animals or humans have demonstrated clear fetal abnormalities, or there's positive evidence of human fetal risk based on experience. And the risks involved in using the drug in pregnant women clearly outweigh any possible benefit. These drugs are absolutely contraindicated in women who are or may become pregnant.
Can you give examples of Category X drugs, ones that absolutely no?
Yes, the list is critical. Alcohol, ACE inhibitors, like we discussed, lithium, methotrexate, an anti-cancer and autoimmune drug, valproic acid, an anticonvulsant, isotretinoin, Accutane, warfarin in the first trimester, thalidomide. The list goes on. Every professional needs to be acutely aware of these.
Okay. You mentioned the idea of a placental barrier being a contradiction, so most drugs do cross.
Overwhelmingly, yes. The placenta is not really a barrier in the sense of blocking things out. It's more of a sophisticated filter and transport organ. Most drugs cross from mother to fetus primarily by simple diffusion, moving from an area of high concentration to low concentration.
What factors determine how easily a drug crosses?
Several key things. Molecular weight is one. Very large molecules, generally over 1,000 Daltons, like heparin or insulin, don't cross easily. Lipid solubility is crucial. Drugs that dissolve easily in fat cross membranes much more readily. The degree of ionization matters. Non-ionized drugs cross more easily than ionized ones. Protein binding is also important. Drugs that are highly down to maternal plasma proteins are less available to cross. And finally, uteroplacental blood flow itself affects the rate of transfer.
Does this change during pregnancy?
Yes, generally drug transfer increases as pregnancy progresses, partly because the placental membrane gets thinner and placental blood flow increases.
Yeah.
#tag B anticoagulants and breastfeeding safety.
Let's touch on anticoagulants, specifically blood thinners. How do we manage those safely in pregnancy? Heparin versus warfarin.
Right, this is a common clinical scenario. Heparin, both the standard unfractionated heparin, UFH, and the low molecular weight heparins, LMWH, like enoxaparin, are the preferred anticoagulants during pregnancy.
Why?
Because they are large molecules, much larger than that 1,000 Dalton cutoff, so they do not cross the placenta. This means they don't pose a direct anticoagulant risk to the fetus. LMWH is often preferred nowadays because it has a longer half-life, more predictable response, and usually requires less intensive monitoring than UFH.
Is there an antidote for heparin?
Yes, protamine sulfate is the specific antidote used to reverse heparin's effects if needed, for example, around the time of delivery or if bleeding occurs.
Okay, so heparin is generally safe for the fetus. What about warfarin?
Warfarin, Coumadin, is very different. It's a small molecule that readily crosses the placenta. It works by interfering with vitamin K-dependent clotting factors.
And the risk?
It's a known teratogen, especially if taken during the first trimester, weeks 6-12 of gestation. Exposure during this time carries about a 5% risk of causing warfarin embryopathy.
Embryopathy, what does that involve?
The classic features are nasal hypoplasia, an underdeveloped nose, and stippled epiphyses, which are abnormal calcifications in the bones, visible on X-ray. Exposure later in pregnancy can cause fetal bleeding or central nervous system abnormalities. So warfarin is generally avoided throughout pregnancy if possible, especially the first trimester. Women needing long-term anticoagulation are usually switched to heparin before conception or as soon as pregnancy is confirmed.
Got it. Now, shifting slightly, what about medication safety during breastfeeding? Do drugs get into breast milk?
Yes, most drugs do transfer into breast milk to some extent, again, usually by passive diffusion. The same factors that influence placental transfer play a role here. Molecular weight, lipid solubility, ionization, protein binding. Non-ionized, low molecular weight, lipid-soluble drugs tend to transfer most readily.
So how do we decide if it's safe for a breastfeeding mother to take a medication?
It's always a benefit-risk assessment. The established benefits of breastfeeding for both mother and infant are huge, so the goal is usually to find medications compatible with breastfeeding if treatment is needed. The key factor is the dose the infant receives via the milk. If the amount transferred is very small, typically estimated at 1 to 2% of the maternal dose, adjusted for weight, adverse effects in the infant are generally minimal or unlikely.
Are there specific drugs that are absolute contraindications during breastfeeding, things to always avoid?
Yes. Certain drugs are considered unsafe due to potential toxicity to the infant. This includes most cytotoxic drugs used for cancer chemotherapy, drugs of abuse like cocaine, heroin, PCP, and radioactive compounds used for diagnostic tests. Breastfeeding usually needs to be interrupted for a specific period after those. Some other specific medications might also be contraindicated depending on their profile. Always best to check reliable resources.
Okay, let's pivot to pain relief during labor and delivery, analgesia and anesthesia. First, what actually causes labor pain? Where does it come from?
Labor pain is complex. In the first stage, it's primarily visceral pain, originating from uterine contractions causing ischemia, lack of oxygen in the muscle, and importantly, from the stretching and dilatation of the cervix and lower uterine segment. In the second stage, as the baby descends, you get additional somatic pain from the stretching and potential tearing of the vagina, perineum, and pelvic floor structures.
And understanding the nerve pathways is key to blocking that pain, right?
Absolutely. You need to know where the signals travel. The motor nerve supply to the uterus involves both sympathetic nerves coming from the lower thoracic and upper lumbar spinal segments, roughly T10 down to L1, and parasympathetic nerves from the sacral segments, S2, S3, S4.
Okay, that's motor. What about sensory, the pain signals?
Sensory pathways follow a similar pattern for the first stage. Pain from the main body of the uterus, the fundus, travels along sympathetic nerve fibers back to those same spinal cord segments, T10 to L1. That's the target area for pain relief early in labor.
T10 to L1 for the first stage. What about later?
As labor progresses, pain signals from the cervix and the upper part of the vagina travel via the pelvic plexus, mainly to the sacral spinal segments, S2, S3, and S4. And pain from the lower vagina and the perineum, that intense stretching pain during delivery, is carried primarily by the epidural nerve, which also originates from S2, S3, and S4.
So S2 to S4 becomes important for the second stage in delivery.
Precisely. Knowing these levels is crucial for planning regional anesthesia, like epidurals or spinals.
Interesting point from the sources, an intact nerve supply isn't actually essential for labor to happen.
That's right. We know this because women with paraplegia, whose spinal cords are severed below the relevant thoracic levels, can still have effective, albeit painless, uterine contractions and vaginal deliveries. This tells us that uterine activity is primarily driven by hormones. Oxytocin maintains contractions. Progesterone withdrawal likely initiates labor rather than direct nerve control, though nerves clearly transmit the pain signals.
And adrenaline plays a role too.
Yes, adrenaline, the stress hormone, has a biphasic effect. At low levels, its beta receptor activity tends to inhibit uterine contractions, which might explain why sometimes labor stalls if a woman becomes very anxious. But at higher levels, its alpha receptor activity can actually excite the uterus and stimulate contractions.
Okay, so the overall goal for pain relief in labor.
The ideal is efficient pain relief without causing significant harm to the mother or baby. Specifically, we want to avoid depressing the baby's respiration at birth and avoid interfering negatively with the progress of labor, like stopping uterine contractions altogether. Unfortunately, no single drug or method perfectly achieves all these goals without any risks, which is why we have various options and why regional techniques are often favored. #B sedatives, analgesics, and inhalation methods.
Let's talk about some of the systemic options first. Opioid analgesics, like pethidine.
Yes. Pethidine, also known as meperidine or Demerol in some places, has been used for a long time, usually given intramuscularly in the early first stage of labor. It's considered a strong sedative, but maybe less effective purely for pain relief compared to, say, an epidural.
What are the main concerns with pethidine?
The biggest concern is its effect on the baby. It readily crosses the placenta. Maximum placental transfer and peak levels in the fetus occur about 2 to 3 hours after the mother gets the injection.
So timing is critical relative to delivery.
Very critical. If the baby is born during that peak effect window, they can suffer from respiratory depression, sedation, poor muscle tone, and difficulty initiating feeding or suckling. It can also reduce the beat-to-beat variability seen on the fetal heart rate monitor, making interpretation harder.
Okay. Are there other opioids used? Fentanyl.
Yes, fentanyl is another option. It's a synthetic opioid, much more potent than pethidine, but much shorter acting. It's often given intravenously in small, frequent doses or via a patient-controlled analgesia PCA pump.
Advantages of fentanyl.
Because it's shorter acting, it might cause less cumulative neonatal depression if used carefully. It also tends to cause less nausea and vomiting for the mother compared to pethidine. The downside is needing more frequent administration due to its short duration.
What if you do get opioid-induced respiratory depression in the baby? Is there a reversal agent?
Yes, naloxone or Narcan. It's a specific opioid antagonist. It can be given to the mother shortly before delivery if needed, or directly to the newborn intramuscularly or intravenously if they show signs of respiratory depression due to maternal opioid use.
Okay. What about benzodiazepines, like diazepam?
Generally avoided during active labor.
Hmm.
We mentioned diazepam, Valium, earlier in the context of eclampsia alternatives. While it's a sedative and muscle relaxant, it causes significant problems for the newborn if given during labor. Hypotonia, floppiness, hypothermia, low body temperature, poor feeding, and respiratory depression. And these effects can last a long time, even up to 3 weeks, because the baby's liver metabolizes it very slowly. It can also wipe out that beat-to-beat variability on the fetal monitor.
So, best avoided. What about inhaled methods? Gas and air.
Yes, the most common inhaled agent is Entonox. That's a premixed gas containing 50% nitrous oxide and 50% oxygen.
Nitrous oxide laughing gas.
That's the one. That's very common, especially in places like the UK. The key is that it's self-administered by the mother via a mouthpiece or mask. She breathes it in during a contraction and stops between contractions.
How effective is it?
It provides moderate pain relief for many women. It's quick-acting, wears off quickly, and doesn't accumulate significantly. It's generally used during the active phase of labor, maybe from about 8 centimeters dilation through to delivery. It doesn't eliminate pain, but helps take the edge off and gives the woman a sense of control. ###see regional neuraxial anesthesia.
Okay, let's move to the big guns. Regional anesthesia, blocking the nerves directly. Epidural analgesia is often called the gold standard, right?
It generally is, yes. Continuous lumbar epidural analgesia. The procedure involves placing a fine catheter into the epidural space. That's the space surrounding the dura mater, the outer membrane covering the spinal cord, usually between the L2 and L3 vertebrae in the lower back.
After a test dose, presumably.
Always after a test dose to make sure the catheter isn't accidentally in a blood vessel or the subarachnoid space. Then, local anesthetic, often combined with a small amount of opioid like fentanyl, is infused continuously or given in intermittent boluses through the catheter.
What level of block do you need?
For labor pain relief, you need to block those sensory nerves from T10 down to S5 to cover uterine, cervical, and perineal pain. If the epidural is going to be used for a cesarean section, the block needs to extend much higher, usually up to the T4 level, to ensure numbness of the entire abdomen.
What drugs are typically used?
Common local anesthetics are bupivacaine, often in a lower concentration like 0.125% or 0.25% for analgesia or ropivacaine. Sometimes lidocaine might be used if a faster onset is needed. Combining with a small dose of opioid usually allows for a lower concentration of local anesthetic, reducing motor block.
What are the big advantages of an epidural?
The main advantage is it provides the most effective form of pain relief available for labor. The mother can be awake, alert, and comfortable, able to participate more positively in the birth experience. APGAR scores in babies are generally very good. And epidurals have specific benefits in certain high-risk situations, like managing labor in women with preeclampsia. It can help lower blood pressure, or for breech deliveries, twin pregnancies, and preterm labor, where minimizing maternal stress is important.
Sounds great. What about the downsides, complications?
There are definitely potential complications, though serious ones are rare with proper technique. The most common immediate side effect is maternal hypotension, a drop in blood pressure.
Why does that happen?
It's due to the sympathetic nerve blockade caused by the local anesthetic. Blocking sympathetic nerves causes vasodilation, blood vessels relax and widen, leading to pooling of blood in the lower extremities and a drop in pressure. This is managed by prehydrating the mother with IV fluids and positioning her tilted to her side to avoid compressing major blood vessels.
Okay.
Other potential issues.
Post-dural puncture headache, or spinal headache, can occur if the dura is accidentally punctured during placement. It's caused by leakage of cerebrospinal fluid. Less common but more serious risks include infection, epidural hematoma, bleeding into the space, nerve injury, or a total spinal.
Total spinal, what's that?
That's if a large dose of local anesthetic is accidentally injected directly into the subarachnoid space where spinal anesthesia goes. It causes a rapid, extensive block that can ascend high enough to paralyze respiratory muscles and cause profound hypotension. It's a major emergency requiring immediate respiratory and cardiovascular support.
Does an epidural affect the length of labor? Good question. Evidence suggests it doesn't significantly change the duration of the first stage of labor. However, it can prolong the second stage, the pushing stage, often by about 15 to 30 minutes. This might be because the urge to push is dulled, potentially increasing the likelihood of needing an instrumental delivery, like forceps or vacuum extraction.
Okay. What about spinal anesthesia? How is that different?
Spinal anesthesia involves injecting a single small dose of local anesthetic, often with an opioid, directly into the subarachnoid space, into the cerebrospinal fluid itself. It's usually done at the L3-L4 or L4-L5 interspace.
Advantages of a spinal.
It provides a much faster onset of anesthesia than an epidural, usually within minutes, and typically produces a denser, more profound block. The success rate is very high. It's commonly used for scheduled cesarean sections or sometimes for forceps deliveries or other procedures needing rapid, reliable perineal anesthesia. The block level needed depends on the procedure, maybe T10 for delivery, but up to T4 for a C-section.
Disadvantage.
The main risks are similar to epidural, but perhaps more pronounced with spinal. Hypotension is very common and can be quite sudden and severe. Respiratory depression is a risk if the block goes too high. And post-dural puncture headache is more common after spinal anesthesia than after epidural, maybe occurring in 5 to 10% of patients, particularly younger women using larger needles. And it's a single shot, so the duration is limited unless a catheter is placed.
Can you combine them, spinal and epidural?
Yes, that's called combined spinal epidural anesthesia, or CSE. It uses a special needle-through-needle technique. You first locate the epidural space, then pass a fine spinal needle through the epidural needle into the subarachnoid space to inject the spinal dose.
I do that.
It aims to give you the best of both worlds. The rapid onset and dense block of the spinal for immediate pain relief, combined with an epidural catheter left in place, allowing for continuous infusion or top-ups to maintain analgesia throughout labor, or for post-operative pain relief after a C-section. CSE techniques sometimes allow for lower overall drug doses, potentially enabling a walking epidural with less motor block.
Interesting. Lastly, what about local blocks? Pudendal blocks.
Yes, local nerve blocks target specific areas. A paracervical block involves injecting local anesthetic near the cervix. It can provide good pain relief during the first stage, but isn't used much anymore due to a significant risk of causing fetal bradycardia, a slow heart rate, possibly due to rapid drug absorption near uterine arteries.
Okay, so paracervical is mostly historical. Pudendal.
The pudendal nerve block is still used. It involves injecting local anesthetic transvaginally near the ischial spines to numb the pudendal nerve, remember S2, S4. This provides excellent perineal analgesia, numbing the vagina and perineum for the second stage of labor, delivery, episiotomy repair, or sometimes for forceps or vacuum deliveries. It doesn't relieve contraction pain, just the perineal pain. #D, general anesthesia for cesarean section.
Finally, let's consider general anesthesia, GA, specifically for cesarean sections. It's less common now with regional being preferred, but sometimes it's necessary, right?
Absolutely. GA might be needed in emergencies where there's no time for regional, if regional anesthesia fails or is contraindicated, like with certain bleeding disorders or infections, or occasionally due to patient preference. But it carries higher risks for both mother and baby compared to regional.
What's the biggest risk for the mother with GA in pregnancy?
The single biggest risk is aspiration of gastric contents. Pregnant women are at extremely high risk for this.
Why is the risk so high?
Several reasons. Progesterone relaxes the lower esophageal sphincter, making reflux more likely. The enlarged uterus physically pushes the stomach up and delays gastric emptying. Plus, pain and anxiety during labor can further slow emptying. If the mother vomits or regurgitates stomach contents while under anesthesia, especially during induction or emergence when airway reflexes are suppressed, those acidic contents can be inhaled into the lungs.
And that causes?
That causes Mendelssohn syndrome, which we'll come back to. It's a severe chemical pneumonitis, inflammation of the lungs leading to hypoxia, lung damage, and potentially fatal respiratory failure or secondary pneumonia. It's a leading cause of anesthesia-related maternal death.
So preventing aspiration is the top priority. How is that done?
Through a very strict, multi-pronged protocol. First, fasting guidelines are crucial, usually 6 hours for solids, maybe 2 hours for clear fluids for elective cases, though in emergencies you assume a full stomach. Second, pharmacological prophylaxis is key. This typically involves giving an H2 receptor blocker like ranitidine or famotidine sometime before surgery to reduce gastric acid production.
Okay.
And just before induction, giving a non-particulate antacid like sodium citrate. This doesn't reduce volume, but it neutralizes existing stomach acid, raising the pH above that critical 2.5 level. Sometimes metoclopramide is also given to speed up gastric emptying and tighten the lower esophageal sphincter. In high-risk cases, a nasogastric tube might be passed to empty the stomach.
What about positioning?
Crucial. The patient must be positioned with the left lateral tilt, usually a wedge under the right hip, throughout the procedure, especially during induction and emergence. This tilt displaces the heavy uterus off the inferior vena cava and aorta, preventing aortocaval compression, which improves maternal blood pressure and placental blood flow.
And the induction itself, is it different?
Yes, it's typically a rapid sequence induction and intubation, RSII. This involves pre-oxygenation, having the mother breathe 100% oxygen for at least 3 minutes to build up oxygen reserves. Then, a rapid-acting intravenous induction agent like thiopentone sodium or propofol is given, followed immediately by a fast-acting muscle relaxant, usually succinylcholine, to facilitate quick intubation.
What's the most critical step during induction for safety?
Applying cricoid pressure, also known as Selleck's maneuver. As soon as the patient loses consciousness, a trained assistant applies firm pressure to the cricoid cartilage at the front of the neck. This compresses the esophagus shut against the cervical vertebrae behind it, physically preventing any regurgitated stomach contents from reaching the pharynx and airway until the endotracheal tube cuff is inflated, securing the airway.
Cricoid pressure is vital.
Absolutely vital. And once the airway is secured, time becomes critical again. The uterine incision to delivery interval, the UD interval, needs to be minimized.
Why?
Because all general anesthetic agents cross the placenta and can cause sedation and respiratory depression in the newborn. The longer the time between starting the anesthesia, or making the uterine incision, and getting the baby out and clamping the cord, the higher the dose the baby receives and the greater the risk of neonatal acidosis and hypoxia. The goal is usually a UD interval of less than 3 minutes.
Less than 3 minutes. Wow, that's fast.
The whole team needs to work efficiently.
You mentioned Mendelssohn syndrome earlier. Can you elaborate on that specific complication?
Yes, Mendelssohn syndrome is that chemical pneumonitis caused by aspirating acidic gastric contents, specifically contents with a pH below 2.5. It leads to intense inflammation, damage to the lung tissue, pulmonary edema, bronchospasm, and severe hypoxia. It can rapidly progress to acute respiratory distress syndrome, ARDS.
How is it managed if it happens?
Management is supportive but aggressive. Immediate suctioning of the airway is vital. Maintaining oxygenation is the priority, often requiring intubation and mechanical ventilation with positive end expiratory pressure, PEP, to keep the air sacs open and maintain arterial oxygen levels, PO2, above 95%. Bronchodilators might be needed for bronchospasm. Antibiotics are usually given if there's evidence of secondary bacterial infection, bronchopneumonia, though they don't help the initial chemical injury. It's a very serious complication requiring intensive care.
Wow. Okay, we have covered an immense amount of ground in obstetrical pharmacology. If we had to synthesize the key takeaways, what stands out?
I think the core insight, especially with the oxytocics, is really understanding the different actions. Oxytocin gives you that physiological coordinated contraction for inducing or augmenting labor.
Right.
Ergot derivatives provide that powerful sustained tetanic spasm used only for hemostasis, for stopping bleeding after delivery. Completely different purpose and timing.
And prostaglandins.
Prostaglandins offer that incredible versatility. They cause contractions regardless of gestation. But crucially, PGE2 also performs that vital physical act of cervical ripening, preparing the way. So distinct roles, distinct mechanisms.
And underpinning all of this is the absolute weight of safety, isn't it?
Absolutely. Extreme vigilance is demanded. We saw the need for meticulous monitoring and titration with oxytocin infusion, the life-threatening risks of vasoconstriction with ergots, the careful balancing act with tocolytics, weighing fetal benefit against significant maternal cardiac and pulmonary risks, and of course, the non-negotiable mandate to understand teratology, those critical developmental windows, and avoid Category X drugs.
The mastery we've aimed for today really does seem to revolve around that precise application and constantly balancing risks, often between two patients.
It truly does.
So looking forward, what's a provocative thought to leave our listeners with? Something building on this.
Well, thinking about how this field evolves, we talked about oxytocin's short half-life, how that necessitates continuous infusion and complicates postpartum hemorrhage management, especially in lower resource settings.
Right.
Now, we know long-acting analogs like carbetocin exist, potentially removing that constraint. So an important question is, how might the wider adoption of such long-acting agents, if proven safe and effective across diverse populations, fundamentally simplify and maybe even standardize PPH prevention protocols globally? Could it drastically reduce maternal mortality from hemorrhage?
That's a powerful thought. Anything else on the horizon?
On the flip side, thinking about pain management, we rely heavily on pharmacology, especially regional anesthesia. But what about non-pharmacological approaches? Things like transcutaneous electrical nerve stimulation, TENS, sophisticated psychoprophylaxis techniques, maybe even virtual reality. Could advancements in these areas fundamentally shift our reliance away from drugs for labor analgesia in the future? Could that potentially change the experience and outcomes of labor for the next generation? It raises interesting possibilities about where the field might go.